Welcome to this video, and we're so pleased to always welcome back Professor Angus Dalgleish. Professor, thank you so much for coming back.
Thank you.
Have you been injured? How important is it to be vitamin D replete when treating cancers?
Well, it is so important that it is pointless, I believe, treating cancer patients until you've got their vitamin D level high, or supplement it with D3 or calciferol. It is so important, and the literature is replete out there. I mean, since we first spotted it with regards to immunotherapy, why do some people fail and other people respond? And we spent 2 years, also spent lots of money on looking at everything going. And then the vitamin D test becomes available to us, and it's immediately obvious. If you've got low vitamin D, it's a waste of time giving them immunotherapy.
So sophisticated immunotherapy treatments, some people respond, some people don't respond, and you find out it's the non-responders have got low levels of vitamin D and the responders have got adequate levels of vitamin D. Can it be that simple?
It is that simple. And it revolutionised our treatment because we measured everybody's vitamin D before going on any treatment. We got it to a decent level, and that's why our randomised study using IMM 101, which is the heat kill bacteria we're talking about, that's why that trial showed a benefit, because we had corrected vitamin D deficiency. Now, there's so many papers out there now. I mean, there's one meta-analysis paper of 88,000 patients looking at patients in trials with all sorts of treatment, all sorts of cancers, where they had measured the vitamin D before starting, and they had some centres which corrected it and others that just left it measured. And the ones that corrected it had a 13% improvement in clinical outcome, whether it be chemotherapy, radiotherapy, mixtures of surgery, whatever it was. And to show you how important this is, that tamoxifen was the ER blocker for breast cancer, the world's first big blockbuster pharmaceutical, had an 8% improvement. So that really puts it into context how important this is. And I mentioned that I'm just horrified that I get calls for people for a second opinion, why they haven't responded, and they've had very, very good treatment. And I'm just horrified that they go to top cancer centres and they've never bothered to measure the vitamin D in spite of all these papers. And I had a guy the other day, I measured his vitamin D, and basically they couldn't measure it. It was so low. So all we have to do to improve his outcome is to greatly improve that vitamin D. And I do find, and this is a problem of big pharma driving the process, the protocols. They're not interested in vitamin D, so it's not even mentioned in a lot of these protocols. And I believe it's negligent. I think the data is so strong, it's negligent not to measure vitamin D before you start treating a cancer patient.
I mean, we've got all the Bradford Hill criteria, really. We've got the epidemiological correlates, we've got the associations, we've got the before and after, we've got the temporal correlation, we've got plausible mechanisms, the immunomodulatory, immuno-optimizing effects of vitamin D. It all makes perfect sense. I mean, poor Bradford Hill. I mean, Austin might be turning in his grave at this, because, why bother doing all this work when it's ignored? It's just
exactly. I mean, it's such a waste of really expensive drugs. And one of the things when we presented the pancreatic data with IMM 101 and at ASCO, and we were the only people to have a survival benefit with a so-called immunotherapy, and the big classic ones that work for melanoma didn't work. And one of the guys, when I presented it, said, why is yours the only one works and all the others don't work? Like he just didn't believe us. Yeah. And I said, well, you'll find that probably we're the only trial that's ever looked at vitamin D levels before we randomise you on the trial and make sure that it's corrected. It's that simple. Well, this guy had done thousands of patients on clinical trials for pancreatic cancer, and he said, I've never heard of this. He calls me up 3 months later. He said, I set it as a project to somebody because all our samples for years are stored. And he said, I cannot believe it. He said, the only people that respond to chemotherapy are the only people that have normal vitamin D. He said, it is black and white. And he said, we certainly will be changing our practice after that.
It's the medical establishment just seems obtuse. They're just determined to be unteachable for bizarre reasons. I'm guessing you want something like 40 milligrams per mil, which is 100 nanomoles per litre, Gus.
Yes.
Does that sound about?
Yeah, absolutely. I think that's the crucial level. The NHS sets it at 50 and say anything over 50 is fine. No, it's not, because it's taken from the normal range of the population, and the normal population is chronically deficient in vitamin D. So with all my years of experience looking at when people benefit, it's over 100 now.
100 nanomoles.
And it's not high dose, it's
per
not
litre.
toxic, because normal's up to 200.
Yep.
It just shows that the majority of people are sitting 30, 40, and some of them I've had as low as 7 or 19. I mean, it's unbelievable. And they look fine, but they don't respond. It's that simple. And, you know, people still say to me, why are you going on about this? Everybody knows it's only important in rickets. It is important in rickets, but that was the insight. It's important in everything.
We're saying, unless we have a large, randomized, well-designed, controlled trial study, we're not going to even look at ivermectin. And we actually sent off a paper showing the initial findings. We did a mini analysis to our local journal, and they wrote back saying they are not going to print anything on ivermectin unless it is a large, randomized, controlled trial. Sorry?
No, go ahead, Colleen, sorry.
So scientifically, one of the tenets of good science is to be able to have repeatability.
Yep.
And these 3 studies actually show that. They had slightly different approaches, but they all showed that it was with ivermectin that you could improve blood saturation.
And it's not just these 3 studies. I mean, I talked to Dr. Pierre Corey.
Yeah.
Way back in, I can't remember. I think it was 2020, actually. He'd done a deputation before, I can't remember if it was Congress or Senate, on steroids, and that was accepted. Then he did another one on ivermectin, and that was not accepted. And it had 10 million views on YouTube in about a couple of days, and then it was taken down. So, and it's doctors around the world who, if you like, were flying by the seat of their pants in 2020, just looking for ways to suit their sick patients. Found ivermectin worked, but this war on ivermectin seemed to crop up, almost a cynic might say, in a coordinated way around the world. Well, warm welcome to this talk. Now, today I want mostly to be looking at this paper here. Ivermectin, a potential anti-cancer drug derived from an anti-parasitic drug, published in the peer-reviewed journal Pharmacological Research. Now, as you would expect, this wasn't published in the United States or the United Kingdom or Australia or New Zealand or Canada. This is actually research from China. So let's get straight into it now. Now, is there a plausible mechanism of action is the first question. Is it conceivable that this could be true? Well, it gives various mechanisms of action in the paper. And we're also going to be looking at some specific cancers which the researchers feel this is efficacious for. But let's start off with mechanisms of action. Now, what they say is ivermectin induces different programmed cell death patterns in different tumour cells. So this is the key thing, programmed cell death patterns. So what seems to be happening here is the body's own way of killing its own cells is activated to kill cancer cells, which of course is exactly what is required in cancer, to get rid of these cancer cells. The main form of ivermectin-induced programmed cell death is apoptosis. So they're saying ivermectin is inducing programmed cell death. Now, apoptosis is just programmed cell death. So like when you were, before you were born, you had tissue between your fingers, and there was apoptosis of the tissue that was formed between the fingers. That's why you have separate fingers. So apoptosis is a perfectly normal process. It goes on in later life as well. And this is stimulating, according to these researchers, stimulating apoptosis in cancer cells. Autophagy is another one, basically self-eating. Lysosomal dependent form of programmed cell death. So lysosomes, lysozyme is an enzyme inside cells that can destroy and digest cells. And proteolysis is an inflammatory-based, proteotosis is an inflammatory-based mechanism. Inflammatory cell death induced by inflammasomes. These are components in the cytoplasm of cells again, which will cause inflammation and destruction of the cells. So mechanisms there do appear to be plausible. And if you look at the paper, now the paper is somewhat complicated, I think it has to be said. But if you look at it, it talks about the different types of cancers. And it also gives some plausible mechanisms in diagrammatic form. Now, these are quite biochemical. I don't intend to run through them all, but they have plausible mechanisms of action that could be working here. For example, that one to generate apoptosis, and another one here to generate another form of cell destruction, or autophagy. And they also have a diagram that illustrates potential mechanisms of action for the proteoptosis, cell destruction. So not ludicrous at all, but of course the key thing is, does this work in real life? Let's just stop now. I want to play a short clip from a cancer surgeon in the United States. This is Dr. Katleen Ruddy. Some links for her there. She's a cancer surgeon, researcher, and author in the United States. Let's get her clip now, and then we'll come back and think about it.
And I was not really even familiar with those people who use ivermectin. And so when, in the early days of COVID, when it became clear that ivermectin was effective in preventing and treating patients with a SARS-CoV-2 infection, I began to be aware, having looked in the literature, that there was 20 years of research showing that ivermectin had great potential in the treatment of cancer. I was introduced to a patient with stage 4 prostate cancer. Had received 2 vaccines, perfectly healthy, marathoner, no history of cancer in the family. 2 months after his second Pfizer shot, he works for the government. He's going to lose his job and his pension if he wasn't vaccinated. He was diagnosed all at once with stage 4 prostate cancer. He tells a very compelling story, melodramatic story about that 24-hour period of time in his life. And he went through the traditional protocols: radiation, chemotherapy, pharmacologic castration, all of it, over a period of 9 months. And then his doctor said, you know, there's really nothing else we can do. And his name is Paul Mann, and he was like, can't you give me more radiation? No. Can't you give me more chemo? No. Aren't there any other drugs? No. Are there any clinical trials? There's nothing. Hospice. Send for the priest. So a friend of his knew me, and she said, would you give Paul a call? He just needs some moral support, something. So I said, sure. So I began calling him. We spoke about once a week for 3 weeks. And finally, the poor guy was suffering, had cancer in 11 bones in his body. His right leg was completely swollen, obstructed with tumor. He's miserable. And I said, Paul, I don't know if this is going to help you, but I know it's not going to hurt you. I just can't imagine, based on my judgment and understanding of the scientific literature and all of the work that Drs. Corey and Merrick had done, and others around the world, that ivermectin would hurt you. It might help. I can't say. So he said, you know, I'll give it a try. And he drove to Tennessee, where you could get it without a prescription. P.S. I discovered last night, having dinner with Paul and his wife, Terry, he drove from where he lives in Missouri to Tennessee and paid cash for his ivermectin. That's it. He didn't submit it to an insurance company. He didn't tell anybody back in Missouri, his oncologist, no. His ivermectin prescriptions are listed in his chart. How did that information get from the pharmacy in Tennessee to his chart in Missouri? We don't know. Somebody does. I'd like to know myself. Anyway, he starts taking ivermectin, and he doesn't have any problems with it. And I talk to him every week. And how are you feeling? Well, no change. Next week, maybe a little bit better. I don't know. How's your leg? It's not quite as swollen. How's the pain? Pain everywhere. Maybe a little bit better. Slowly, slowly, slowly. Not getting worse. Not necessarily getting better, not getting worse. Fast forward. 2-month follow-up appointment at the clinic. They didn't expect to see him. Okay, he's like, Paul. He's feeling a little bit better. They do PSA, which was off the charts to begin with. And if I'm not mistaken, at the time they randomized him to hospice, I think it was in the hundreds, maybe 700, 800.
What does that mean exactly for the layperson?
Over 4 would be abnormal. Okay, so what are we talking about here? Prostate cells normally secrete a protein, prostate-specific antigen. It's one of the things that they do. Cancer cells that originate in the prostate that are dividing rapidly and growing fast are spitting out PSA, okay? It's not that they're contributing to the body economy in any way. It's just they just want to multiply and divide, and that's the end of the story. And so your PSA levels start to rise, which is a marker, a screening marker. Oh, your PSA was 4, and now it's 8. Let's do a prostate ultrasound, whatever. So PSA can be a screen for the emergence of a tumor, but it can also be used, particularly at high levels, as evidence for cancer, response to cancer, recurrence of cancer. His was, I mean, it's supposed to be, 4, yeah, it's hundreds. Okay, he goes back for his 2-month appointment. It's 1.3. They said, you're in remission. Well, not, complete remission. He still had the bone mets, but you're in like a biochemical remission. Well, that was good news. Slowly, 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 he begins to improve. Less pain, swelling is okay. A lot of other vaccine injuries, however, he's getting better. He's getting better. We're giving him nutritional support and other supplements. So he's getting better. But 9 months later, he's out dancing for 4 hours, 3 nights a week. He gets a head-to-toe rescanning, and 3 of the bone mets are gone. There's no growth of the mets that are there, no new lesions. There's only one hot spot, and that's where he received radiation therapy, and the radiologist really could not distinguish whether that was a tumor hot spot or radiation change. He is doing very well. The vaccine injury is a problem. But the cancer is no longer a problem, except for the fact that it's still there, and we want to get rid of it completely. And he said, he called me from a hockey game, and he said, if I didn't know I have cancer, I would not know I have cancer.
Well, based on 20 years research, stage 4 prostate cancer, over-the-counter drug in Tennessee, and that's from a cancer surgeon, researcher, and author. So the thing about this is ivermectin is a remarkably safe drug, and if you're very ill anyway, it's hard to think of a reason not to try things that you might not normally try. And obviously what we should do, is patently obvious what we should do, is people that would elect to try this should be free to do so, under the supervision of their doctors, of course. And a cohort should be generated and data should be collected. And if this was available, I think we would get a few thousand patients in the first cohort within a few weeks. Because sadly, we've got people around us dying of cancer now. So many of you have been touched by cancer deaths. I've had so many correspondence and comments on that. And tragic, I only mention this because it's now in the public domain, but Sir Chris Hoyer diagnosed with stage 4 prostate cancer. It's only 48, very poor prognosis with current medical treatment. A lot of this around. Why not try this and develop a cohort? Let's hope the regulatory authorities are listening and take this on board. It's just such an obvious thing to do. So let's just look at a few other cancers that this paper, remember we're looking at this paper here, Ivermectin, potential anti-cancer drug derived from an antiparasitic drug, data research from China. Other forms of cancer that are mentioned in this paper, breast cancer is mentioned, malignant tumour produced by gene mutations in breast epithelial cells, milk-producing cells. Digestive system cancers, gastric, of course, is stomach, and hepatocellular liver. Again, they're mentioned in this paper with some evidence. Why not try it? Urinary cancers. Renal cell, that's kidney cancer, of course. Mentioned in the paper with possible mechanisms of action. Prostate cancer, as we've just heard from Dr. Ruddy. Hematological, blood, leukemia. Reproductive system cancer, cervical cancer. Ovarian cancer, again mentioned in the paper with mechanisms of action. And at brain glioma, glioblastoma, very poor prognosis. Respiratory system cancers, nasopharyngeal, nose and throat. Lung cancer, melanoma of the skin. And it's not just here. I've just included a few other papers. I'm not going to go through them all. There's a few other papers there with references that list these potential benefits. Now, it sounds pretty far-fetched that one drug could be efficacious against cancers in so many diverse areas. But if it is working in this way, and if it's disrupting the mechanisms of action, which I've misplaced now, but if it's disrupting the mechanisms of action that we mentioned, the apoptosis, the programmed cell death, the cell death within the cells, the lysosomal cell death, and the inflammatory mechanisms of cell death, then if these mechanisms are being stimulated and are killing cancer cells, then it's plausible. And in my mind, even without spending $10 million on a clinical trial, people that want to try this should be allowed to, not just people that live in Tennessee. And data should be collected and cohorts developed and their progress followed. This will cost essentially nothing. If it's completely useless, in the vast majority of cases under medical supervision, the ivermectin is going to be very, very, very safe drug, way safer than ibuprofen, for example, or paracetamol. And our cohort could be developed and amazing things could be learned. Now, of course, the downside is that pharmaceutical companies might lose sales on really expensive, modern, patented drugs. So that's not all good news. But in my view, there's just no reason not to develop these cohorts and make this available to people that would choose to try this. You know, if someone's dying and they think, you know, I just think I quite fancy a large glass of single malt whiskey from the Isle of Lewis, then flipping neck, let them have it. Let them try whatever they want. And that goes for drugs that could potentially alleviate their condition. Potentially. Why not try it? And as people choose to try these drugs, we can build up huge amounts of evidence prospectively. So someone with a terminal condition may say, well, you know, I've got advanced prostate cancer. I would like to try taking ivermectin alongside my traditional treatments. Or some people might say, well, my traditional treatments have failed. I've now got metastatic prostate cancer. I'd like to try ivermectin on its own, or ivermectin with fenbendazole or some other drug. And then that data can be prospectively collected. And the people that chose not to have that drug, they would be the control group. And would end up by collecting huge amounts of data in very small amounts of time, rather than running phenomenally expensive, often biased, randomized controlled trials. Why don't we do that? We could collect 1 million pieces of data from combinations of countries in no time at all. Then we would know. And the potential for treatments for cancer at essentially zero cost would be available. Now I'm just going to close with another quick message from Dr. Katleen Ruddy. Now we did look at a video clip from Dr. Ruddy just recently, and she talked about a patient with basically terminal metastatic prostate cancer, who basically dramatically improved, essentially was cured, taking ivermectin. Let's listen to another account from her now, and then we'll close. For now, thank you for watching.
A second patient crossed my path. A guy in his 70s who had been losing weight for a year and a half, 40 pounds, not vaccinated, 40-pound weight loss, smoker, drinker, all he does is fish. And he could no longer swallow, and he could hardly talk. And so I got on the phone with him, and I said, Eddie, tell me a little bit about your history and so forth. He knew someone with prostate cancer who had taken ivermectin, had cured himself from prostate cancer with that. So Eddie began taking ivermectin. I have no idea what the dosing was. He was just taking it. And I gave him some advice about diet and, try and get the weight back on and so on and so forth. Within a couple of weeks, he sounded stronger. Mm-hmm. Sounded stronger. He could swallow. He had gained 6 pounds. His voice was better. Followed him for the next couple of weeks, maybe another month or so, and I said, Eddie, we need to get a scan. He doesn't have insurance, he doesn't like doctors, whatever. He had been diagnosed in that interval with 2 esophageal tumors, unresectable. Surgeons wouldn't go near it. The doctor said, well, we'll give you chemo and radiation, and Eddie said, no, you're not. So he takes his ivermectin, and maybe about 6 weeks later, I said, Eddie, you need to get a scan. I had to argue with Eddie to get a scan. We got the scan. No tumors. Gone. Gone. The problem was that he had sold his fishing boat. That was the biggest problem. He was getting better. His tumor was gone. Now he needed to go out and buy another fishing boat. That was the second patient. I was like, well, now that's interesting.
Yeah. And that's another interesting thing that we showed. If you gave the patients this IMM 101 or VACI first, and then they relapsed, and you had to give them one of the new approved immunotherapy agents, which had a 40% response rate. And we published this recently, my colleagues published it. We showed if they were primed with the innate immune boost, and then they had the checkpoint inhibitor, Pembro, Keytruda, Nivo, Optivo, the various, they're all roughly the same. The response rate was nearly double with no added toxicity.
Because you're upgrading the immune system ready.
Yeah. So that is a fantastic outcome. Again, we cannot get the big pharma to be interested in this, even though they're aware of it. It's rather like they just don't want to know.
Interesting, the possibilities of the IMM, the mycobacterium vaccine, combined with vitamin D and ivermectin. I wonder how many cancers that would treat.
Well, it's a study I would love to do. You would call it a basket or an umbrella type of trial. You just all comers. You just add it in, and then you would just monitor: are we getting better responses? That's what I would love to do, because you have you start from a position, unlike COVID vaccines, that they're safe.
Yes.
Years down the line, there are no SAEs above 2 for any of the studies, and they're over. I calculated there's about 4,000 patients have had VACI or Imodulin, because it started out in the big TB studies, and so there's no significant side effects. Just at the site where you give the intradermal injection. You might get a big reaction there, although that's good. It means the immune response is working to it. Some people worried it gets infected, and we've swabbed hundreds of them. They're never infected. What appears the infection is a very strong macrophage, which has very strong anti-tumour activity response. So
the inflammatory response just shows that it's working.
And we showed that it correlates with cytokine changes that you measure from blood in your arm, which are very expensive to do. But we showed they correlate beautiful with reaction on the arm. So once the reaction on the arm is really settled down, if they've got a cancer, you give them another one.
Yeah, and the cytokines show you're getting a systemic benefit as well. Yeah.
So it's incredibly practical and pragmatic.
The other thing that a lot of people feel strongly about, and I do, if people have got, say, stage 4 cancer, then there is no reason not to try these things. So anyone with stage 4 cancer, prostatic cancer, for example, we think of the tragic news of Sir Chris Hoy over the past few days, 48 with bony metastases from stage 4 prostatic cancer. I mean, anyone in that situation who wants to try ivermectin and vitamin D and IMM should be allowed to.
Yeah, I agree.
And then these patients would opt into this, and then you would develop a cohort in no time at all, because patients would be opting in. Compare those to the patients that didn't opt in, and I strongly suspect you'd see a very profound difference in mortality within months.
Well, I mean, I've got prostate patients, not ivermectin, but the IMM aspect, who have been completely stable since starting on it. I mean, just no progression, whereas before they were having progression. So just that agent, and vitamin D, of course. But and then the other one I've been using, which is like the ivermectin because I can get it, is the low dose naltrexone, which I mentioned before, because that damps down the chronic inflammation that is associated with cancer spreading. So I would actually include that as well, and then with what we've learned with the ivermectin, none of them I don't think would interfere with each other.
Interesting to hear you say that they wouldn't interfere with each other. And as we find that these drugs are efficacious, potentially we could start titrating down the more conventional chemotherapeutic agents, the more specific ones. We don't know that. That's pure speculation. But
we don't know. But what I can tell you is that in my career, I've lost count of the number of people who saying I'm not going to have chemo because they knew people who had terrible responses with it, or I've persuaded a lot of people to have chemo on the grounds the chemo I use, like for melanoma, it's not that toxic if you play it right and say, you're thinking of people who've had really high dose aggressive treatment for breast or lung or something. It's not like that. But I've met so many people who've just said, no way, I'm not having it, I'll try anything else. And more recently, you might remember being brought to your attention, but Ellie Macpherson was in the Daily Mail having said that she'd got breast cancer, and she had looked and done a lot of research and wasn't going to have any chemotherapy herself. So even some high profile, very intelligent people are saying, no, I'm not prepared to go down that route.
Yeah, they'd rather die than suffer that amount of... Yeah, absolutely. But again, I mean, to these people, ivermectin should be available over the counter as far as I can see, and they're simply free to try it, collect the data, then would know. It's just outrageous.
I remember my wife saying she could get it over the counter for scabies for the children, and that's mysteriously disappeared.
I mean, ivermectin does seem to be in really short supply, despite the fact that they can produce it by the ton in drug factories. It does seem to be getting very expensive and hard to find.
It's ridiculously expensive, and I think this is pharmaceutical manipulation. I mean, I'm prepared to voice my speculation because there's no other logical reason for why something that could be produced in the tons, sold for pennies, distributed to millions of people a day, should suddenly become difficult and extremely expensive in the West.
Yep. My last ones I imported were from over the counter from India, so it's still we know it's still available, still produced. So it just seems to have difficulty diffusing around the world these days. you want to mention this about the vitamin D positive results?
I mentioned about it boosting the checkpoint inhibitors, and I put it the third line, which says IMM enhances MDC. That means myeloid-derived dendritic cells and natural killer and gamma delta T cell. I was at a presentation.
These are all immune cells.
Immune cells.
Protective immune cells.
Where they different people have done this work, and they presented when I was at an immunotherapy conference just before the lockdown occurred in America, and I was staggered. People showed that if you didn't have activated myeloid dendritic cells, the checkpoint inhibitors wouldn't work. And they said, this is what you've got to do to make them work. And to go to another demonstration another day, and another group would say, here's the secret. If you don't activate natural killer cells, the checkpoint inhibitors won't work.
And they can only be activated with the vitamin D.
Here we have one agent that did both of this in-depth research. And we've shown in a small study that it doubles the response rate. So almost certainly through these mechanisms that others have elucidated so comprehensively.
Yeah. So there's, in your view, there's no oncological treatment that would be adversely affected by making a patient vitamin D replete prior to the commencement of treatment?
No, none.
There's no contraindication here. All patients should be vitamin D replete. Full stop. That's the end of it.
Period.
Yeah, absolutely. Yeah. So this.
I think we can jump. Well, actually, this is very interesting.
No, go for it. Yeah.
This was a paper published by in Nature Medicine by Chantels and the group, which just pure looking through the literature. What cells control cancer? Now, the entire industry of immunotherapy thinks it's CD8 and CD4, but this showed quite categorically the
CD8s are the T helper cells and
the gamma delta
killer
T cells at the top with the arrow there, the gamma delta T cells. Now, my group has spent the last over a decade showing that gamma delta T cells are the ones that you really want in cancer, and they've shown that beautifully. Daniel Fowler and others in a series of papers, and here we have something that confirms it just from an observation status. They didn't go out to show that. They just said which ones are the most effective, and they found it was the gamma delta, and of course the IMM boosts that gamma delta cell beautifully, where most other immunotherapies don't.
So to put it simply, these gamma delta cells are a subset of T cells, but their activity is boosted by giving a few dead bugs intradermally.
Yes, the gamma delta cells are basically they are a cell midway between the very, very primitive T cell that has no recognition of anything particular, and the adapted T cell, which when mature will see a specific antigen through cytotoxic T cell lymphocytes will kill it. It's halfway through there, and it would appear that this is far more important than the highly evolved, sophisticated pathways which we've all been trying to manipulate.
Yes.
So once again, it's a simplicity which is so attractive and exciting because it's very practical to do so.
So we have these fairly crude cells. I'd call them natural killer cells. Is that right?
Yeah.
Fairly big lymphocytes.
Just slightly more evolved than the natural killer cells. Yes.
But obviously, we've got a spectrum of these in the body. Precisely for this reason.
Exactly.
It's amazing, this spectrum of cells from a rather crude thug that goes around beating up any cell it finds to one with a very precise antigenic target. And we have a spectrum of these. And because the Mycobacterium IMM is polyclonal, it's got the potential to stimulate many subgroups of cells.
Without a doubt. I mean, there's so many different types of antigen in the Mycobacterium. There's sort of lipids and gangliosides and all these various different presentations. And I think that's why it is so effective, because if you set out to make a product without using this as the stepping stone, you would never think to add all those things in together. You'd only ever do one or two at a time.
And that's the big mistake. Well, it's not the mistake, it's deliberate. The pharmaceutical industry is targeting one very precise thing because that's patentable. Whereas patenting a bacteria would probably be slightly more tricky for them.
Well, the protections in the manufacturing process,
Right.
that's really where all the skill set is.
Yeah.
Because it's very easy to produce a load and it's not effective. So that's where the skill set is in preparing this.
But your mates could. The skill's ready to go. If they press the button, they could produce tons of this stuff.
The company, Imogenum, have got the patents to protect this.
So Imogenum could make enough to vaccinate the whole country within a few years if the government said go.
Yeah, exactly. Yes. The beauty of this is that you don't need to resort to gene therapy, as I call messenger RNA. You don't need to resort to this to produce millions of doses quickly. These things grow so fast that you can produce millions of doses quickly. You don't need
just like making beer, isn't it? You just chuck a load in and culture them. Yeah.
Yes, that is the best. It's like yeast.
Yeah.
Just like yeast.
Yeah, I mean, they'll presumably divide every 40 minutes or something, and get infinite amounts.